good evening to my dear friends who have joined here to the continuation of your autonomic nervous system and the pharmacological drugs that are discussed here. We have already completed cholinergic system, both cholinergic agonist as well as the antagonist. And yesterday we covered adrenergic agonist. Today we are going to cover adrenergic blockers. Okay. Before moving to the core topic of adrenergic blocker, you already know that there are only two concepts as far as your autonomic nervous system is concerned. Autonomic nervous system abdinale, either it is going to be cholinergic, okay, or it is going to be, I want interactive in the chat box. I want everyone to interact in the chat box. So cholinergic na, it is going to be acetylcholine. Autonomic nervous system or other part is adrenergic. Adrenergic system or main part yaru. Adrenergic system or main part is going to be your adrenergic main part on adrenaline. Adrenaline is going to be the main part of your adrenergic nervous system. Clear? Okay. Now moving on towards adrenergic nervous system la nama paatha drugs enna. Adrenergic nervous system rendu vagaya nama pirikalam. Again alpha beta. Alpha is again divided into alpha 1, alpha 2. Alpha 1 is further classified as alpha 1A, alpha 1B and alpha 1D. Coming to the alpha 2 is a feedback mechanism. Remember, alpha 2 is a feedback mechanism. We divide into alpha, beta. Alpha is further classified as alpha 1, alpha 2. The alpha 2 is going to be a feedback mechanism pandra oru part. Okay, beta, alpha. This rendula, someone can you tell me which is a stimulant and which is an inhibitor? You have two things, alpha, beta. Among this, which one is a stimulator? Which one is an inhibitor? Can anyone? If you have attended yesterday's session, you will know alpha, beta. Rendu irukku. Idhula edu vandu stimulant, edu vandu inhibitor. This is what my question is. Someone? Remember, always alpha is going to be, you have two receptors, alpha, beta. Always alpha is going to be a stimulator. Beta is going to be a inhibitor. Okay, wow. Very good, Medico. Alpha is a stimulator, beta is a inhibitor. And among alpha, which one is going to be a contradictor? Or among the beta, which one is going to be a contradictor? You know what I mean by contradiction? Stimulant, alpha is a stimulant, nama solrom. Adila edo oru part vandu, it is going to be inhibitor. Adhe my beta is always inhibitory, except in one part, which is a stimulant. Anyone? Okay, I myself will tell. Alpha is always a stimulant, except in your GIT, where it is going to be a inhibitor. Similarly, beta is always going to cause inhibition of a function, except in your heart, where it is going to cause a stimulation. It is going to increase the force of contraction. It is going to increase the inotropic, chronotropic, heart rate, force of contraction. Rendume increase agum. It is also going to increase the AV conduction function or conduction velocity. Very good, very good. So once you know this concept, then we moved forward to discuss about the drugs. Okay, wow. Adala adrenaline first part, which is going to be a norepinephrine, epinephrine. This rendu da nama paathom. Norepinephrine, epinephrine. Adukapram vandi total function of your adrenaline. So adrenergic nervous system mottama, how did we classify? Rendu system. One based on the function, innone based on the receptor where it is going to act. What I told you in the entire video is based on the receptor, and finally we also saw the adrenergic drugs based on the function. So what are the function it is going to have? One is a pressure agent. Another one, it is going to act as a bronchodilators, cardiac stimulants. It is going to act as a nasal decongestants. It is going to act as a CNS stimulant. It is going to act as a uterine relaxants. It is going to act as a anoretics. இதுதான் நம்ம டோட்டலா படிச்சோம். இதுல எதுவுமே டவுட் இருக்காது உங்களுக்கு, because you have already saw the entire session of the adrenergic nervous system, adrenergic stimulants. Now today what we are going to discuss, is about the adrenergic blockers. Okay, shall we move into the adrenergic blockers? So, adrenergic blockers is otherwise called as sympathetic blockers. It is otherwise called as sympatholytics. Lytics na enadhu, which is going to destroy. So, adinala nama sympatholytics no solrom. Okay va. Idhula irundhu ungalku essays are asked. Okay. So, idhula irundhu ungalku essays கேட்டிருக்காங்க. So, அதனால நம்ம கொஞ்சம் டீடைல்டா we will see about this adrenergic blockers. ஏன்னா adrenergic blockers are going to play a major role when you take hypertension. When you are going to take hypertension, adrenergic blockers plays a major role. Cardiovascular system la majority of diseases you will be giving with adrenergic blockers. That is why adrenergic blockers are given with utmost importance. Okay va? So your adrenoreceptor is classified as alpha beta. In the kadayada na vandu starting of the session la I told you, I once again revised. So you already know that alpha to beta. இதுல வந்து எது எப்படி ஆக்ட் பண்ணுதுன்னு. Your beta is going to act by adenyl cyclase. Your alpha 1 alpha 2 இதுல எது வந்து IP3 DAG மூலமா ஆக்ட் பண்ணும்? Your alpha 1. Your alpha 1 acts by IP3 DAG mechanism. IP3 DAG என்ன பண்ணும்? Calcium வந்து it is going to stimulate and it is going to cause smooth muscle contraction. Apart from the smooth muscle contraction, what is going to be your alpha 2 function? Alpha 2 acts as a feedback mechanism. Okay, so it is going to act as a feedback mechanism and inhibit the transmitter release and keeps a check on the adrenergic hormones production. Okay va? So now coming to the sympathetic blocking drugs. Okay, so adrenergic blockers, what it is going to do? I already discussed in the cholinergic that any blocker is going to act by two ways. Either it is going to bind with the receptors. Okay, either it is going to bind with the receptors, or it can do the other way. It can increase the reuptake of your adrenergic. It is going to increase your reuptake of your adrenergic hormones like your adrenaline, noradrenaline, phenylephrine, whatever it may be. So these are the two mechanisms by which your sympathetic blocking drugs are going to act. Okay, so coming back, your sympathetic blockers is going to act by depleting the catecholamines from various parts of the body. That is how your reserpine and your tetrabenazine is going to act. Or it can interfere with the synthesis of adrenergic transmitter. You know that from phenylalanine, you're going to get a dopa. From dopa, you're going to get a noradrenaline. From noradrenaline, you're going to get adrenaline. So in the process, inhibit பண்ணலாம். பண்ணா நமக்கு என்ன ஆகும்? Your sympathetic agents oda amount will be less. So that is one point. So that is how your alpha methyl paratyrosine is going to act. Other one is it can interfere with the transmission of impulse across your postganglionic adrenergic neuron. That is how guanethidine is acting. And finally, some things can block your adrenergic receptor, and the adrenergic receptor block பண்றதா we call it as a alpha blocker, beta blocker. Okay va? Now first topic we are going to move forward, that is your alpha blocker. Alpha receptor antagonist is going to block the adrenergic response mediated through your alpha adrenergic receptor. Some of them might also selectively block. Example, alpha 1 மட்டும் block பண்ணலாம், இல்ல alpha 2 மட்டும் block பண்ணலாம். Okay va? So now moving forward, alpha blockers are the drug that inhibit adrenergic responses mediated through your alpha adrenergic receptor without affecting your beta receptor. So beta receptor la தான் உங்களுக்கு என்ன இருக்கு? Your art is going to be there. So art functions affect பண்ணாம alpha receptors function ஆக முடியும். So அது என்னென்ன drugs அதை தான் நம்ம பார்க்க போறோம். Now coming to the, you already know that alpha 1 alpha 2 ரெண்டு இருக்கு. ஓகேவா? So alpha 1 எங்க இருக்கு, alpha 2 எங்க இருக்கு, இது தெரிஞ்சாதான் நம்ம எதுக்காக alpha 1 blocker கொடுக்கிறோம், எதுக்காக alpha 2 blocker கொடுக்கிறோம் நமக்கு தெரியும். So I think it is better to take a pick at this point of time. ஒரு pick எடுத்துக்கோங்க இந்த ஒரு tableau column. This is very very important for you. This is very very important for you. Okay, moving forward. So what is the alpha 1 blocker and what is your alpha 2 blocker? Alpha 1 blocker are present in the smooth muscles of your blood vessel. It is present in the iris. It is present in the salivary gland. It is present again in your GIT. What is the function? So smooth muscle contraction is a function except your GIT where it is going to cause relaxation. Similarly, when a dog is chasing you, only example that we always remember is when a dog is chasing you, you should not have increased saliva secretion. So that is why what happens, there will be a decreased salivary gland secretion. How does it act? IP3-DAG. I told you. இதுல alpha 1A, alpha 1B, alpha 1D இருக்கு. ஏன் இந்த subtypes importantனா, again, these subtypes will be present at specific places. So you can target that place to give a increased action. Now coming to the alpha 2. Alpha 2 is present in the, especially in your CNS, especially it is present in your pancreatic beta cell. It is present in the platelets. It is going to be present in the vascular smooth muscle. Okay, wow. So these are the 4 places where you are going to have a alpha 2. So what it does, it is going to decrease your central sympathetic flow. It is going to decrease your central sympathetic flow. It is going to decrease your insulin release. It is going to increase the platelet aggregation. They are going to cause smooth muscle contraction. Is it clear? Okay. Now, adrenergic receptor antagonist is broadly classified as alpha receptor, beta receptor. If alpha receptor mattum nama paapom, beta receptor marandrunga. Alpha receptor, again you divide into non-selective, alpha 1 blocker, alpha 2 blocker. Okay, what is a non-selective? Non-selective, na, it is going to block both your alpha 1 and your alpha 2. So non-selector enna pannu? So your non-selector is going to block both alpha 1 as well as your alpha 2. So alpha 1, alpha 2 ரெண்டுத்தையும் block பண்ணது. Alpha 1 block பண்ண என்ன ஆகும்னா, main alpha 1 is present in your blood vessel. Therefore, it is going to cause vasodilatation. So once there is a vasodilatation, that is going to cause decrease in the blood pressure. If there is a decrease in the blood pressure, it is going to cause reflex. It is going to cause reflex tachycardia. It is going to cause reflex tachycardia. Now coming to the alpha 2. What does your alpha 2 do? So when you're going to block your alpha 2, so there is no okay, there is going to be alpha 2 is going to be blocked. But alpha 2 block பண்ணா மட்டும் உங்களுக்கு noradrenaline synthesis increase ஆகாம இருக்குமா? கண்டிப்பா noradrenaline synthesis increased தான் இருக்கும். அப்ப வெறும் noradrenaline மட்டும் increase ஆயிட்டே இருக்கும். When there is an increase in the noradrenaline, what it does, it is going to ultava causes beta stimulation. So noradrenaline நிறைய இருக்கு, alpha is not accepting it, or your alpha 2 is not accepting it. Therefore, only your beta is going to take all your noradrenaline that is synthesized, and that is going to cause increase in the blood pressure. That is going to cause increase in the heart rate. அப்ப என்ன ஆகும்? There is going to be increase in the heart rate. There is going to be increase in the BP. So அப்ப what happens ultimately? This is going to again cause tachycardia. So in the ரெண்டு tachycardia சேர்ந்து what happens is there is a significant raise in the heart rate. There is a significant raise in the heart rate. Always remember, okay, always remember, beta blockers use பண்றப்ப இந்த ஒரு point you should never forget. Alpha block, sorry, I'm very sorry, alpha blockers use பண்றப்ப you should always remember this. வெறும் alpha blockers use பண்றீங்க, அது non-selective alpha blockers நீங்க யூஸ் பண்றப்ப it is going to act both on your alpha 1 and your alpha 2. Alpha 1 will also cause reflex tachycardia. Alpha 2 will cause tachycardia. Both these things are going to increase the heart rate. Now you know what is the mechanism by which non-selective alpha blockers are causing increase in the heart rate. Clear? Okay, now this is a non-selective. But எதுக்கு அடுத்தது வந்து பாத்தீங்கன்னா selective. Okay, we are going to move towards selective alpha 1 blocker. Alpha 1 blocker என்ன பண்ணும்? So alpha 1 block ஆகுது, ஆனா alpha 2 block ஆகல. அப்ப vasodilatation ஏற்படுது, ஒரு BP கம்மி ஆகுது, there is a reflex tachycardia, that is mild tachycardia. But at the same time, your alpha 2 blockers are not going to be present. So alpha 2 receptors block ஆகல. Once there is no blockage of alpha 2, there will be a reduced noradrenaline synthesis. So அங்க உங்களுக்கு block ஆகாதனால noradrenaline synthesis கம்மி ஆகாது, ஏன்னா feedback mechanism கிடையாது. Alpha 2 is always related to the feedback mechanism. When alpha 2 is not blocked, there is no issues about the feedback. Therefore, noradrenaline is not going to be secreted at all as excess. Therefore, no significant tachycardia. Therefore, alpha 2 block பண்ணாம வெறும் alpha 1 block பண்ற மாதிரி drugs required இருந்தது. That is why there was advancement to have a selective alpha receptor blocker. I guess you can understand how all these things are going to function. Okay, thus predominant effect of non-selective alpha blocker. So ஒரு non-selective alpha blocker நான் யூஸ் பண்ண போறேன். So ஏன்னா நம்ம இப்ப பிரிப்போம் non-selective, selective அப்படின்னு we are going to classify. அந்த மாதிரி classify பண்றப்ப predominant side effect or adverse effect என்ன இருக்கும் அப்படின்னு பார்த்தோம்னா it is going to be tachycardia with hypotension. So tachycardia with hypotension. Is it clear to all? Is it clear to all? Okay. Selective alpha blocker, அதாவது alpha 1 செலக்டிவா நம்ம பிளாக் பண்றது, it is not going to cause significant tachycardia, and again it can cause hypotension. That is why selective alpha 1 can be used in the hypertension. Now alpha 2 மட்டும் செலக்டிவா நான் பண்றேன் உல்டாவா. Just let you think. Alpha 2 மட்டும் I am going to target, alpha 1 I am going to leave. அப்ப என்ன ஆகும்? alpha 1 மட்டும் நான் வந்து டார்கெட் பண்ணேனா it is of no use. It is going to increase your noradrenaline, it is going to increase your BP, it is going to increase your heart rate. So what happens is there is a hypertension. So அப்ப நீங்க hypertensionக்கு alpha 2 blocker கொடுத்தீங்கன்னா it is of no use. Alpha blocker can also result in meiosis and nasal stuffiness. So alpha blocker in a bladder and prostrate will be leading to the decreased resistance to the flow of urine. Okay, so இதெல்லாம் நான் பார்த்துட்டேன். Now what you're going to do is, I already told you, whenever you're going to come to a session, what you're going to have in your hand, you're going to have your KD Tripathi classification book. You're going to have KD Tripathi classification book. In the KD Tripathi classification book, you can see alpha adrenergic blocking drugs. You will be having a page where you're going to have the drugs that are going to be alpha adrenergic blocking drugs. So on the page number எடுத்துக்கோங்க. அதுல you're going to have first classification. First, how you classify it. So you're going to classify it as either non-selective blocker, selective blocker. Non-selective again going to be reversible, irreversible. அப்படின்னு நம்ம ரெண்டா செலக்ட் பண்றோம். Okay, so reversible, irreversible first என்ன வருது? Phentolamine, tolazolin. So phentolamine and tolazolin, அவங்க ரெண்டு பேர் reversible. Irreversible is your phenoxybenzamine. So that is why your phenoxybenzamine is called as non-equilibrium type. Okay, so what group of drug it belongs to? Phenoxybenzamine belongs to beta alloalkylamine. Beta alloalkylamine. But avlo serious ala, you don't want to remember anything. Just remember one thing. As I told you already, okay, your phenoxybenzamine, it is going to be a non-selective alpha blocker, which is a irreversible. Clear? So first we will see the reversible drug, that is your phentolamine. Phentolamine என்ன பண்ணும்னா alpha 1 alpha 2 ரெண்டு பேரையுமே ஈக்குவலா பிளாக் பண்ணுது. அப்ப noradrenaline release is increased and venodilatation is going to be predominating. So what is the diagnosis and intraoperative management of pheochromocytoma? Where do you use this? In the diagnosis and management of pheochromocytoma. Okay, so what it is going to do, in addition to the alpha 1 alpha 2 blocker, it can also going to block your 5-HT. What is 5-HT? Serotonin. So it is also going to block your serotonin receptor. Okay, and what it does, it can increase the gut motility. So அப்படியே just remember, so gut motility alpha decrease பண்ணும். அப்ப இது என்ன பண்ணும்? gut motility increase பண்ணும், gastric secretion increase பண்ணும். Because of it, what is going to be the side effect? Side effect is going to be vomiting, diarrhea. So side effects என்ன இருக்கும்? Vomiting, diarrhea. So these rendume, okay, you take phentolamine, you take tolazolin, so both are going to have this same mechanism of action. Okay, so where you use this phentolamine? Phentolamine is used for controlling the hypertension due to clonidine withdrawal and a cheese reaction. 5 mg IV as and when required, you're going to give. Okay, repeat pannalam. Okay, now coming to the phenoxybenzamine. Very, very important. Phenoxybenzamine can be asked as a short note, question. In any university, you will be having a short note from phenoxybenzamine. So what is a phenoxybenzamine? It is going to bind covalently to the alpha receptors and they are going to cause a irreversible blockade. So irreversible blockade agudhu. So when you are going to give us IV, blood pressure gradually falls over 1 to 2 hours and this is going to be associated with tachycardia and raised in cardiac output. So BP reduce aga. What happens is there is an increase in the sympathetic tone. It is going to cause increase in the sympathetic tone. There will be a shift of blood from your pulmonary to your systemic circuit and there will be a shift of blood from the extracellular to the vascular compartment. So this is what your phenoxybenzamine is going to do. So the action is going to last for 3 to 4 days, and it also blocks your histamine, serotonin, and cholinergic receptors. Phenoxybenzamine can be given orally, but absorption is incomplete and should not be given as IM or SC route. So it is only given as a IV administration. It is always given as a IV administration. That is what is important. Adverse effect என்ன அப்படின்னு பார்த்தோம்னா, I already told you, so postural hypertension, palpitation, nasal blockage, meiosis, and inhibition of ejaculation. Why all these things are occurring? Palpitation, I already told you, tachycardia cause பண்றனால அது. Postural hypertension ஏன் வருது? I already told you, because of the increase in the sympathetic tone and venodilatation. Why there is going to be nasal blockade? So nasal blockade ஏன் வருதுன்னா, மூணு இம்பார்ட்டன்டான பார்ட்டை நம்ம வந்து பார்த்தீங்கன்னா பிளாக் பண்றோம். apart from your alpha blocking, that is your histamine, serotonin, cholinergic. So that is why it is used. Okay, so இப்ப இந்த non-selective, okay, இந்த non-selective ஏ நம்ம எங்க யூஸ் பண்றோம் அப்படின்னு பார்த்தோம்னா, always remember all your non-selective alpha blockers are used in only one condition, pheochromocytoma. So it is always used in one condition, pheochromocytoma. Apart from it, there is no other use of a non-selective alpha blocker. Okay, va? So now coming to the selective alpha blocker, very, very important question. Selective alpha blockers, you're going to have a prazosin, terazosin. Always remember, all zosin is going to be alpha 1 receptors. All zosin except your tamsulosin, again, that is also going to have a zosin. So prazosin, terazosin, doxazosin, alfuzosin, and your tamsulosin. இது எல்லாமே ஓசின் அப்படிங்கிற இதுல முடியுது. இது எல்லாமே they are going to be a selective alpha blockers. Is it clear? Now what happens in the selective alpha blockers? I'll tell you. ஓகேவா? ஸோ செலக்டிவ் ஆல்ஃபா பிளாக்கர்ஸ்ல என்ன ஆகுதுன்னா, ஸோ இது எல்லாமே ஒரு குரூப் ஆஃப் ட்ரக். ஸோ இவங்க எல்லாருமே என்ன பண்றாங்கன்னா, ஆல்ஃபா 1 மட்டும் டார்கெட் பண்றாங்க, ஆல்ஃபா 2 டார்கெட் பண்ணல. whenever they are going to be coming to the alpha 1, it is going to be going through IP3 DAG mechanism. now இருக்குல்ல, so your alpha is going to be going through IP3 DAG mechanism. இந்த IP3 DAG mechanism ஆகலனா, there will be no calcium increase, no activation of protein kinase C. So therefore what happens, in the இடத்துல தான் it is going to activate. The GQ-ங்கிறது G protein coupled receptor is not going to be acting by phospholipase C to increase your calcium, This is how your system is going to act. So what is the exact role of your selective alpha 1 blocker? Now you have to go to your, what are the places where alpha 1 is present? So what are the places where your alpha 1 is present? Your alpha 1 is present in blood vessels, your alpha 1 is present in the iris, your alpha 1 is present in the bronchi, GI, uterus, and okay, urinary bladder. I already told you, except GIT, in all other places, what is going to be a role of your alpha blocker? So alpha stimulation, மத்த எல்லா இடத்துலயும் going to cause contraction, except your GIT where it cause relaxation. அப்ப alpha 1 செலக்டிவா நீங்க டார்கெட் பண்ணீங்கன்னா என்ன ஆகும்? What will be the role of your alpha 1 blocking? So 1, in your blood vessel, it is going to cause dilatation. So what happens? There is going to be a venodilatation. What happens in your iris? In iris, it is going to, in your eye, it is going to cause relaxation. And then what happens in your bronchi? Normally bronchus எப்படி இருக்கும்? Bronchus is going to, bronchus genitourinary smooth muscles என்ன ஆகும்? ரிலாக்ஸ் ஆகும். genitourinary smooth muscles எல்லாமே contracted இருக்கும், இங்க ரிலாக்ஸ் ஆகும். லிவர் கிளைகோஜினோலைசிஸ் ஏற்படும். ஓகே, இங்க வந்து கிளைகோஜினோலைசிஸை ப்ரிவென்ட் பண்ணலாம். அதான் உன்னோட alpha 1 ஓட வேலை. So that is what they have given in this. So alpha 1 will cause, reduce your peripheral vascular resistance. It will cause peripheral pooling of blood. It will cause fall in the BP. So what it does, it is going to cause fall in the BP, and it is going to cause fall in the BP, and it is going to cause postural reflex is going to be interfered. Postural reflex, what happens? It will be interfered. Okay, va? So with this you are complete. All you can you understand what is happening until this? Can anyone respond if you can understand whatever happening, whatever I told? Someone please respond in the chat box so that I can continue. Are you all there? Okay. Someone Medico, all were responding. I think if you are there, kindly respond to me. Monica, Shivaranjini. Fine. Okay, thank you, thank you. Thank you for your response. Okay, so let me continue. What was the effect of your alpha blocker? I'll tell you one by one. First, I'm going to move towards the cardiovascular response. So cardiovascular system, how your alpha 1 blockers are going to be playing a role. So alpha 1 blockers enna pannom appdi nama paathona. So the smooth muscles of your blood vessels like your alpha 1, alpha 2 vasoconstriction. So alpha blocker, what happens is, so it is going to cause vasodilatation in both your arterioles and your veins. This causes decrease in the peripheral vascular resistance. This will be again cause decrease in the venous return and decrease in the cardiac output. And finally, this will cause fall in the blood pressure. So that is your hypotension. Okay, what is the effect on the heart rate? In heart rate, it is going to cause reflex tachycardia. I think I have explained in a short and brief way in the beginning itself. There will be a stimulation of your baroreceptor reflex. This causes increase in the sympathetic discharge and this causes increase in the heart rate. Okay, though beta 1 is the one which stimulates your heart rate, even when you block the alpha, there will be a reflex tachycardia. So nasal stuffiness, எதனால வருது? Nasal stuffiness is due to the blockade of your alpha receptors in the nasal blood vessels. Because of the vasodilatation, you will be having congestion. This is going to, and second thing is, it is going to alleviate the symptom of BPH. Why? Because of the smooth muscle relaxation of your bladder neck, your urine flow will be improving. So even your benign prostate hyperplasia, what is the major difficulty? So this is going to be your bladder neck. Okay, so this is going to be your bladder neck, trigone or bladder neck, whatever you call. In the இடத்துல தான் உங்களுக்கு what happens is, there will be a presence of your prostate gland. Here only you will be having your prostate gland. So what exactly happens in your benign prostate hyperplasia? There is a growth of the prostate gland which will be further causing narrowing of your neck of your bladder. Whenever there's a narrowing of your neck of your bladder, your urine flow is going to be disturbed. So when there is going to be a relaxation of your smooth muscles present in this part of the bladder of the neck of the bladder, what happens? It will give some improvement to the urine flow. And failure of ejaculation and impotence occurs. Why? Due to the inhibition of contraction of your vas and ejaculatory ducts. So, unga vas and ejaculatory ducts vandu contract agama irukadanaala ejaculation will be an issue that you are going to write in the adverse effect of any drug. And then coming to the meiosis. So it is going to cause meiosis. Why? Due to the loss of tone in the radial muscles. Okay, now vasomotor reversal of Daley. I guess yesterday itself I talked about it. Prior treatment with alpha 1 blockers will be preventing the pressure response of epinephrine. Unopposed vasodilating by beta 2 effect is observed. Usually pressure response of epinephrine is reversed to vasodepressor response. This I have told you. Okay, now coming to the alpha 1. I'll talk in detail about the alpha 1. So alpha 1 oda effects எல்லாத்தையுமே நம்ம அப்படியே if you read, you can understand and read, then you will be able to write for any alpha 1 blocker all the mechanism of action and side effects you can write very easily. So first we will start from the eye. Radial muscle of eye, there will be contraction. All arterioles, there will be constriction. G80, there is going to be secretion and relaxation. Sphincters are going to cause contraction. Trigone of sphincter, again contraction. Uterus is going to be contraction of alpha 1. Sex organs, it is going to cause ejaculation. This is the role of your alpha 1. So இது எல்லாமே நான் என்ன சொல்றேன்னா alpha 1 ஓட ரோல் நான் சொல்லிட்டு இருக்கேன். ஓகேவா? So pilomotor contraction, sweat gland secretion, heart will be causing arrhythmias. Now what happens? So this is going to be again alpha 2. Alpha 2 ல வந்து மெயினா என்ன பண்ணும்? So decrease sympathetic outflow, pancreatic beta cells நால there will be decrease in the insulin secretion. Okay, now coming to the prazosin. First and foremost, prazosin is a potent, highly selective alpha 1 blocker with 1000 times affinity for the alpha-1 receptors. All your arterioles or venules are going to be dilated. So அப்போ ஆல்ரெடி நான் சொன்னது என்ன, இங்க வந்து blood vessels எல்லாமே என்ன ஆகும், constriction ஆகும் alpha-1னால. So அப்போ alpha-1 நீங்க block பண்ணீங்க அப்படின்னா என்ன ஆகும், there will be a dilatation, there will be a dilation of your blood vessels. So that is what we are telling here. So okay, so prazosin is going to block your vasoconstriction and causes vasodilatation, and this is going to lead to fall in the BP, and fall in the BP will cause reflex tachycardia. It is going to dilate arterioles more than a venules. That is very important. So it is going to dilate your arterioles more than your venules. Okay, so there is no significant tachycardia. நீங்க அந்த அளவுக்கு யோசிக்க வேணாம், ஒரு reflex tachycardia தான் இருக்கும். It is also going to decrease the sympathetic outflow, central sympathetic outflow. How? The enzyme that degrade your CAMP, adenosyl monophosphate, அதை வந்து block பண்ணும், because of which there will be increase in the cyclic AMP. So cyclic AMP வந்து பாத்தீங்கன்னா அதை destroy பண்ணக்கூடிய enzyme prazosin is going to block. So because of this, there will be a rise in the cyclic AMP. Cyclic AMP rise ஆதனால it will further cause vasodilatation. Clear? So which will further cause vasodilatation. Okay, now coming to what are the other actions. So prazosin and its congeners, terazocin, doxazocin, இது எல்லாமே வந்து பாத்தீங்கன்னா tamsulosin, இவங்க எல்லாருமே they are found to decrease your LDL and triglyceride and increase your HDL. ரொம்ப ரொம்ப important ஆன point. Okay, so they also relax your urinary bladder neck and prostatic capsule, because of which they are very much useful in the prostatic hypertrophy. So prazosin is orally effective and has a oral bioavailability of 60%. Okay, so but what is going to be the problem? They are highly bound to the plasma protein. They are metabolized in the liver. Okay, you're going to use it in the antihypertensive, Raynaud's disease, and your benign prostate hyperplasia. But what is going to be the adverse effect? Adverse effect now, it is going to cause postural hypotension. So what will be the adverse effect? So it is going to cause postural hypotension. It is going to cause nasal congestion. It is going to cause male sexual dysfunction. I'll again tell you, there is one important point you should note, that is the first dose phenomena. What is this first dose phenomena? I'll tell you. First dose phenomena அப்படினா என்னன்னா, so 1 hour after the initial dose, there will be a marked postural hypotension. So what happens because of it? There is going to be a leading to fainting. So what is the first dose phenomena? Initially, first time when the patient is going to take, there will be a marked postural hypotension. So because of this, what happens is there is going to be a fainting. So what you must do to avoid this, prazosin must be started with a lower dose, 0.5 mg தான் நம்ம ஸ்டார்ட் பண்ணணும். Okay, and அதுக்கப்புறம் கொஞ்சம் கொஞ்சமா you can raise it. So how much you can give this prazosin? 1 to 4 mg you can give. 1 to 4 mg, either you can give it as a BD or you can give it as a TDS. Either you can give it as a BD or you can give it as a TDS. Okay, so prazosin 2 gram, 2 mg, 1 mg, 0.5 mg. இது மூணுலயுமே you're going to marketல available இருக்கு. So one of the common drug is going to be prazopress. PRAZO, இது வந்து 0.5, 1 mg, 2 mg, இந்த மூணு டோசேஜ்லயுமே available. Now coming to the congeners of prazosin. So what are the congeners of prazosin? So prazosin அப்புறம் என்னென்ன வந்தது? Terazocin. Then what are the other things you know? Tamsulosin. You also know toxazocin. இவங்க எல்லாருமே congeners. Why you want a congener? I'll tell you, all these congeners are going to be long acting, so that you can give only once daily. They are highly selective for your alpha-1 receptor. Third one, your postural hypotension is milder than with prazosin. Postural hypotension will be milder than with the prazosin, and there is no significant effect on the cardiac function. So that's the cardiac part, it is not going to touch anything, and LDL will be decreased, HDL will be increased. That is very useful. And one other thing is your tamsulosin. What it does is it is going to selectively act on the alpha 1A. Alpha 1A la selective alpha no. Because of that, it can relieve yourself from the BPH with mild fall in BP. So alpha 1 is further classified as A, B, D. Idhila B da vandu pathengana, sorry, idhila A da vandu pathengana, it is present in your, it is going to be present in your urinary bladder. Therefore, it will be helpful for relieving you from the symptoms of your benign prostate hypertrophy. So, benign prostate hypertrophy, which drug you will be giving? Alpha 1A blockers you will be giving. And the alpha 1A blocker or example here, tamsulosin. Similarly, you have this terazocin, doxazocin. Ivanga rendu perume hypertension la you will use. And you read one more drug, you remember? Alfuzosin. What is this alfuzosin? Alfuzosin are very useful in the benign prostate hypertrophy. Again, alfuzosin is useful in benign prostate hypertrophy. And now coming towards the, you have two important new drugs which are formed. One, urapidil. What is urapidil? Urapidil is alpha 1 and a weak beta 1 blocking agent, which is again used in the hypertension and your benign prostate hypertrophy. And other one is going to be indoramin. What is indoramin? It is a selective alpha 1 blocker. It is used in the treatment of benign prostate hypertrophy. I think you are all clear with all these things. Now, terazocin, ye nama kondu vandom. Ore oru clenching point oda I will complete all this congeners. Terazocin, less potent and more action for alpha 1 receptors. So, duration of action 18 hours ku mela. Hypertension, benign prostate hypertrophy you are going to use. Terazocin again as a higher bioavailability. Number one point you should know, single daily dose nama kuduka mudiyum. It is more popular because of the apoptosis that is going to occur, which will be promoting the apoptosis effect on the prostate, and prostate apoptosis erpadana. This is very useful for relieving yourself from the benign prostate hypertrophy. That is why you will be giving. Next one, doxazocin, why you give? Doxazocin, it is going to be highly selective alpha 1. Again, elimination 20 hours. Duration of action is almost 1.5 days. So, adinala it is important. Now, coming to the doxazocin. Doxazocin is again used in the hypertension and BHP. It is as an effect on prostate. Now, coming to tamsulosin. Tamsulosin has a greater potency by inhibiting the contraction of prostatic smooth muscles. Better oral BA than your prazosin. But what is going to be the adverse drug effect? It will cause abnormal ejaculation. It will cause floppy iris syndrome. It will cause floppy iris syndrome. That is why you will be not using tamsulosin. Now your question arises, isn't it? Now what question you have to ask me at this point of time? Tamsulosin is causing an abnormal ejaculation, I told you. Why there is an abnormal ejaculation? Two important point you can take. One, it is going to increase vasodilation. It is going to cause a vasodilatation. If vasodilatation that will also cause decrease in ejaculation, number one. Number two, floppy iris. Number two, it is going to increase the flow area. So, ejaculation, it requires more pressure, and because of that, there will be a failure of ejaculation. Okay, so they are going to have failure of ejaculation. When the tamsulosin is not preferred in usage of your prostate hypertrophy because they are lacking the prostatic apoptosis promoting property. Adinala ipa terazocin da use பண்றாங்க. So alfuzosin வந்து use பண்றது கம்மியா இருக்கு because the patient will have a hepatic problem. So hepatic impairment இருக்கிறவங்களுக்கு you cannot use this. Okay, next one வந்து பாத்தீங்கன்னா நீங்க ஒரு point I will tell you, that alone you remember. Yohimbine கறதுல no clinical role. Again, you don't use this because they can cross blood-brain barrier. They can cause blood-brain barrier. Okay, so autonomic insufficiency will be caused by promoting the norepinephrine release. So, எங்க நீங்க யூஸ் பண்ணலாம்னா diabetic neuropathy, postural hypotension, அங்கெல்லாம் வந்து you can go. And to reverse the antihypertensive effect of clonidine, you can go for the yohimbine. So, okay, now we have completed all these things. Okay, now we have completed all these things. Okay, alpha blockers ellame I think you are over. Okay, so now coming towards what is a clonidine. Okay, clonidine is imidazole derivative. Okay, they have a role in the bradycardia, sedation, and hypertension. They are alpha 2 agonists. That's clonidine. So, adverse effect is dry mouth, sedation, sexual dysfunction, marked bradycardia. Now coming to the non-selective irreversible blocker, I think I already discussed phenoxybenzamine in detail, phentolamine in detail. Okay, tolazolin we have also discussed. Now coming to overall usage of your alpha blockers. Number one, pheochromocytoma. So estimating the urinary CA metabolite, that is your catecholamine metabolite. So yeah, vinyl mandelic acid, normetaphrine, this is used as a diagnostic test. So what it is going to do? So you're going to have this pheochromocytoma phentolamine test can be asked as a 1 mark question, MCQ கேட்கலாம். It can be asked as a short note also. So you're going to inject phentolamine 5 mg IV over 1 minute in the recumbent subject. So when there is a fall in BP more than 35 millimeter of mercury, it is an indicative of pheochromocytoma. So therapeutic phenoxybenzamine, prazosin can be used as an alternative. Clear? So hypertension you can use alpha-1 selective agents. Okay, but it is not used commonly. Benign hypertrophy you use alpha-1 adrenergic blockers like your prazosin, and you also use 5-alpha reductase inhibitor like your finasteride. So they are going to cause arrest in the growth and reduce the size of your prostate. Alpha-1 adrenoreceptors in your bladder is going to also help in increasing the smooth muscle tone. So they can be blockade in the dynamic component. Alpha-1 blockers afford faster and greater symptomatic role. Okay, so congestive cardiac failure also you can use. Okay, so phentolamine induced penile erection therapy. It is used in the impotence. Again, this is very important. What is the injection you will give? Injection papaverine 3 to 20 mg with or without phentolamine. So this is going to induce a penile erection. It is going to induce a penile erection, which is going to be a therapy in your impotence. It is going to be a helpful in impotence. Okay, clear? Is it clear? Okay. Now, what are the adverse effects of your alpha blockers? Orthostatic hypotension, like your venodilatation, reflex tachycardia, non-selective more than selective, first dose hypertension, hypotension and syncope within 30 to 90 minutes after the first dose. Then nausea, vomiting, headache, giddiness. So caution in patients with coronary artery disease. So angina you should not use. This is going to be your adverse effect. And due to the blockade of your alpha receptors in your vein of lower limb, so this is going to cause increase in the venous tone. It will cause pooling of your blood on standing, postural, or your orthostatic hypotension can occur. So again and again. So this also you can take a screenshot if needed. Okay, now coming to the side effects of alpha blockers. Everything is clear, right? Finally, what is the take-home message you're going to take? Palpitation, sexual dysfunction, vertigo, orthostatic hypotension. Now tell me, I think 7 of you are there, 6 of you are there in this class now. You just let me know, a 70-year-old male presented with the complaints of weak stream of urine, sense of incomplete bladder voiding, urinary frequency, nocturia. After a physical and ultrasound, he was diagnosed with a benign prostate hypertrophy. So he is prescribed with a tablet terazosin, 1 tablet daily at the bedtime. He took the medicine as per the advice. At night, what happened? He got up to pass urine, he got fainted. What is the reason for, what will be the reason for fainting attack? What is the reason for prescribing terazosin? Okay, can anyone tell me? This is a very easy question which I asked. Someone in the chat box? Please, someone, if you are there, someone you can just put in the chat box. Okay, I myself will tell. What is the reason for prescribing terazosin? So terazosin, what it is? Terazosin is a selective alpha-1 receptor. It is going to be a congener of your prazosin. It has increased bioavailability. You are going to give for benign prostate hypertrophy. You are going to give for benign prostate hypertrophy. They are uroselective. That is why you are giving. Second thing, what is the likely explanation for fainting attack? It is first dose phenomena. It is first dose phenomena. Okay, so what can be the precaution you can give? So precaution 5 mg start பண்ணக்கூடாது. So what is the precaution you are going to give? Instead of starting with the 5 mg, you are going to give at the கம்மியான dose you're going to give. How much you're going to give? 0.5 mg first நாள் கொடுத்துட்டு கொஞ்சம் கொஞ்சமா you have to raise. So this is what you go for the Terrazocin. Terrazocin initially 1 mg கூட start பண்ணலாம். 1 mg start பண்ணிட்டு then you can slowly move forward. So 0.5 mg is for Prazosin most commonly. When you go for the Terrazocin, you can go for 1 mg. Okay, 1 mg is the starting dose. Okay, now coming towards the alpha receptors, எல்லாமே நம்ம பார்த்துட்டோமா? Alpha 1 agonist used in the treatment of nasal congestion, hypothalamic இது. Alpha 1 blockers, it is used in hypertension and treatment of benign prostatic hypertrophy. Now coming to the alpha 2 receptor, 2 agonist is used in the hypertension treatment, 2 blockers are used in yohimbine. அப்ப alpha 1 blocker alpha 2 agonist both can be used in the treatment of hypertension. Both can be used in the treatment of hypertension. Is it clear till now? Is it clear till now? Shall I move forward? Okay, fine. I'll start with the beta blockers now. So when you're going to start with the beta blockers, so what do you know about the beta blockers? So எல்லா beta blocker they are going to end with olol. olol அப்படிங்கிற அந்த ending தான் இருக்கும். ஓகேவா? When you go for the drug chart, so you have your KT Tripathi classification, right? In the classification, if you take, you are going to have a drug chart. எல்லாமே பாருங்க, most of it are going to end with the name OL. Okay, இப்படிதான் it is going to end. Okay, what is going to be the action? So you all know that except beta, okay, beta is a inhibitory mechanism, except when your beta in your heart, where it is going to cause stimulation. இததான் நம்ம படிச்சோம் first, correct? So it is going to cause stimulation. This is what we read earlier. Okay, sir, one more time. Which one do you want one more time? The Terrazocin and the iduva? Is this what you are telling? Monica, is this what you wanted to explain again? This alpha 1 and alpha 2. Okay, remember alpha 1 alpha 2 ரெண்டு இருக்கு. alpha 1ல ஒன்னு வந்து agonist, இன்னொன்னு antagonist. Okay, இதுல alpha 1 blocker is used in the treatment of hypertension. Okay, alpha 2 வந்து பாத்தீங்கன்னா it is going to be a feedback mechanism. So alpha 2 agonist கொடுத்தீங்கன்னா அதுவும் causes reduction in the hypertension. So that is why alpha 2 agonist can be given in hypertension. Alpha 1 blocker is given in hypertension. So clear? Alpha 1 block panna hypertension case, you will be reducing your BP. When you're going to increase the alpha 1, when you're going to increase the alpha 2, then also it is going to reduce your BP. That is what I'm telling you. Is it clear? Shall I move forward, Monica? Thank you. So இது என்ன பண்ணும்? பீட்டா ஸ்டிமுலேட் பண்ணுது. So பீட்டா ஆர்ட்ல மட்டும் என்ன பண்ணும்னா it is going to stimulate. Therefore you will be having a increase in heart rate, increase in force of contraction, increase in the AV conduction. It is going to increase in the AV conduction. So this is what we already know. Now I'll tell you one thing which is not going to be known to all. Okay, so இந்த beta blockers என்ன பண்ணுனா it is going to increase your heart rate or decrease your heart rate. You're going to block your beta receptor, therefore there will be a decrease in heart rate, there will be a decrease in the force of contraction, there will be a decrease in the AV conduction. Again I am repeating to you, AV conduction, இந்த எல்லா force of contraction, heart rate, இது எல்லாத்தையும் எப்படி கண்ட்ரோல் பண்ணுதுன்னா vagal receptors மூலமா கண்ட்ரோல் பண்ணுது. How through vagal receptors? I'll tell you. By vagal receptors, how it is going to do is it is going to cause a ionotropic effect. உங்க SA node இருக்கு பாருங்க, அந்த SA node stimulate பண்ணும். அதுதான் உங்களோட all your parasympathetic nervous system and sympathetic nervous system is going to act. So stimulate பண்ணி it is going to cause increase in the conduction system. So heartல ஒரு conduction system இருக்குல்ல, அந்த conduction system it is going to stimulate. So that is how it is going to act. இங்க beta block ஆகுது, therefore there will be a reduction in the force of contraction, decrease in the AV conduction, decrease in the heart rate. Is it clear to all? Is it clear to all? Now I'm moving towards the beta blockers. Okay, so beta blockers order broad classification. If you're going to take in your book, it is going to be telling that your beta blockers can be classified as beta adrenergic blockers, alpha adrenergic agonist. Okay, so sorry, again I'm repeating. Beta blockers you can divide it into two things: non-selective, selective. Non-selective na it can act both on the beta 1 as well as beta 2. Can act on both beta 1 as well as beta 2. And what is going to be the blocking drug is specific cardio selective அப்படின்னு சொல்லலாம். Cardio selective na especially it is going to act on the beta 1 selective drugs. அதுவும் நம்ம சொல்லலாம். So is it clear to you? So beta 1 selective drug அப்படின்னு நம்ம சொல்லலாம். So ரெண்டு பார்ட் நம்ம பார்த்திருக்கோம். ஓகேவா? So or else what you can do is it can also be classified based on the generation. How do you classify based on generation? It can be divided into first generation, can be divided into second generation, it can be divided into third generation. So it can be divided into first generation, second generation, third generation. Clear? First generation drugs என்னெல்லாம் வரும்னா older non-selective drugs. எல்லா non-selective drugs you're going to classify it under first generation. What are the non-selective drugs you're going to classify under first generation? Number 1, propranolol. Number 2, timolol, sotalol and pindolol. ஓகேவா? 4 ட்ரக் நான் வச்சுக்கோங்க. இவ்வளோ நிறைய நான் வச்சுக்கணும் அவசியம் இல்லை. Remember propranolol. Propranolol is very important. So you are going to remember propranolol. Next, second thing is going to be timolol. Third thing is going to be your pindolol. Okay, these are the things you are going to remember. 2 P நான் வச்சுக்கலாம். Propranolol, pindolol. இது ரெண்டும் PA. So you can remember it. T for timolol and S for sotalol கூட you can remember. Second generation அப்படின்னா என்னன்னா it is a cardio selective. Beta 1 selective or cardio selective. What are the cardio selective drug present in this? Metoprolol. ரொம்ப important. Atenolol is important. You are going to have a bisoprolol, esmolol. How I remembered in my exam is I remember it as MABE, MAB. So what is MAB? Metoprolol. Then you are going to have your atenolol. Then you are going to have acebutolol. Then you have this bisprolol. Then you have this esmolol. So these are the four things which I remembered. Then coming to your third generation. Third generation enna aguna you are going to have a alpha blocking. Okay, it is going to be very non-selective that we alpha beta inga alpha viyume block பண்ணும் or vasodilating property இருக்கு. Example is going to be your labetalol. Example is going to be labetalol, carvedilol, celiprolol and bitoxolol. So in the non-selective வந்து பாத்தீங்கன்னா it cannot differentiate your beta 1 and your beta 2. இது வந்து it cannot differentiate between your alpha and beta. It also have a alpha property. So that is what your third generation drug. So third generation drug na என்னன்னு தெரியுதா இப்ப? Is it clear till now? So what is a third generation drug? It doesn't differentiate alpha and beta. It also has a alpha blocking property. It also have a alpha blocking property. Hope you all can understand this. Okay, now moving forward with, so what are the beta blockers? Beta blockers oda main prototype yarna propranolol. Propranolol அப்படிங்கறவங்க தான் beta prototype na first important classification la first drug eduna prototype drug da. So it is classified based on beta subtype selectivity, partial agonist activity, lipid solubility and local anesthetic given. All are going to be competitive antagonists. So you have 3 generation. I already told you what are the 3 generation. Now coming to the pharmacological action of each and everything. First I will go for the cardiovascular system. So heart la enna agudhu, your beta blockers are going to decrease your heart rate. They are going to decrease the force of contraction. They are going to decrease the cardiac output. So there is going to be fall in the blood pressure level. So the effect is more pronounced in the presence of increased sympathetic zone than your normal situation. So AV conduction is going to be delayed. Again, what happens? There will be a decrease in the AV conduction. Because of it, what happened? There is going to be arrhythmia. Okay, because of it there is going to be arrhythmia. Why? Because of the blockading effect of the beta receptors in your AV node. So myocardial oxygen requirement is also going to be reduced because of the reduced cardiac work. Beta blockers are very important to improve the exercise tolerance in your angina patient. So they prevent the exercise induced increase in the heart rate and your force of contraction. So high dose of the beta blockers will be producing a membrane stabilizing activity like your quinidine, causing direct depression of your heart. Now coming, what is going to be the effect on blood vessels? So in blood vessels, so beta blockers are going to reduce your BP, or they're going to fall in BP. How? By evoked by isoprenaline, and they are going to be enhancing your rise in BP by adrenaline. So there is going to be vasodilatation. So remember, I will again explain this. Beta blocker will be causing a peripheral vascular resistance. Okay, on a long-term goal. Long-term use or peripheral vascular resistance cause pannu. You know what is the role of a beta blocker? Beta blocker will cause, okay, beta blockers enna pannu usually beta first action of beta enna agum smooth muscles. Anyone know what is the action of beta on smooth muscles? It is going to cause inhibition dana. So this beta on the usually enna pannu? Someone? Okay, I myself will tell. So normally adrenergic systems, what it does is it is going to relax your, so it's going to cause vasodilatation to the vital organs, and it is going to cause constriction to the other organs. So inga idu vasodilatation this beta blockers are going to block, and this will go, and fall in BP will be evoked by your isoprenaline, and enhancement of BP will be done by adrenaline. But remember, beta blockers per se, correct Monica, correct Arshita, beta blockers per se doesn't cause any effect in your blood vessel. Prolonged administration only can cause fall in BP, but as such, your beta blockers doesn't have any function. I'll tell you how beta blockers will be causing a fall in BP on prolonged usage. It doesn't act on the blood vessels. Remember, prolonged action of your beta blockers doesn't act on the blood vessel directly, but what it does is it is going to reduce your renin release. It is going to reduce your renin release. In turn, what happens? This is going to decrease the central sympathetic mechanism. Central sympathetic mechanism decrease agumbodhu, thereby it is going to cause decrease in BP. This is how your entire blood vessel function is going to occur. It doesn't not going to have a direct emphasis on your blood vessel. Now coming to why you use it in the anti-hypertension. Okay, remember, continued treatment, okay, it is going to cause decrease in the cardiac output and decrease in TPR by decrease in the renin release. So adan na sonna renin release nala da nama anti-hypertensive action nama use pandrom. It is not going to have a direct effect on the blood vessels. Is it clear? Now coming to respiratory, very, very important. Important side effects of your beta blockers. Enna appdi nama pathona, they are going to cause bronchoconstriction. So or asthma patient ku beta blockers kudukalama, kudukka koodadu. You should never give asthma patient ku beta blockers because they cause increased airway resistance and they precipitate acute attack of status asthmaticus. ரொம்ப ரொம்ப important. Next, கண்ணில் என்ன ஆகும்? Many beta blockers will be reducing the intraocular pressure by decreasing the secretion of aqueous humor. Next, coming to the CNS, they reduce the anxiety. They are going to reduce the anxiety, and they are going to be reducing anxiety in the stressful situation. But long-term use causes mild depression, forgetfulness, and increase in dreaming. So local anesthetic use பண்ணலாம். Propranolol is acting as potent as your lidocaine. It is not used in the as a local anesthetic. Why? Because irritation at the site of injection. That is why you don't use it therapeutically. Okay, now coming to the metabolic action, this is again very important. So lipid metabolism, it is going to inhibit adrenergically induced lipolysis. Therefore, there will be decrease in free fatty acid level, and there is going to be reduction in the HDL and increase in the LDL. Do you remember alpha blockers action on the ultava irukum? They will be increasing your HDL and they will be decreasing your LDL, but this causes increase in the LDL and decrease in the HDL. Clear? Again, glucose mechanism, this is going to inhibit the glycogenolysis, and they are going to be helping in recovery from insulin will be delayed, and there will be decrease in the insulin release. Okay, electrolyte pathona, this will cause hypokalemia. Clear? Next, we are going to move towards skeletal muscle. So adrenergically induced tremors blocked by the beta blockers. So it reduces the exercise capacity. Beta 2 mediated increase in the blood flow to muscle will be causing inhibition of your glycogenolysis, lipolysis. This will be reducing your cardiac output. I is clear, I guess. Then uterus, it causes relaxation by beta agonist is inhibited. So normally when the uterus, it is going to cause relaxation. And always remember your beta action will be inhibition. So therefore, it is going to cause relaxation. So beta agonist inhibit பண்றதுனால it will be occurring. Now coming to the, so நம்ம இது வரைக்கும் பார்த்ததெல்லாம் இம்பார்ட்டன்ட் கிடையாது. இனிமே நம்ம பார்க்க போறது இம்பார்ட்டன்ட். What is that? Beta 1 selective, cardio selective. So நம்ம main function of your beta வந்து பாத்தீங்கன்னா cardiac action தான். So beta blockers ஓட main function வந்து பாத்தீங்கன்னா cardiac blockers. இதுதான் எக்ஸாம்ல கேட்பாங்க. Therefore you have to remember this beta 1 selective drugs. All the beta 1 selective drugs, it is equally important, very important. Okay va? Before I move towards the beta 1, so if I use as pharmacological action, what will be the adverse effect? You can tell yourself what is the adverse effect of it. Bradycardia is going to be a common. CCF, congestive cardiac failure occur because of the beta blocking. Cold extremities, peripheral vascular diseases, cold extremities varalam. Beta blockers can precipitate acute asthmatic attack. That is one of the side effects. CNS insomnia, depression, fatigueness வரலாம். Metabolic effects நம்ம பார்த்தோம். And abrupt withdrawal of your beta blockers will be in a prolonged usage can cause rebound hypertension. I want you to remember this. And your beta blockers can also cause dizziness. So what are the important mechanisms? So drug interactions you have to remember. So propranolol insulin onna கொடுத்தா என்ன ஆகும்? So beta blockade mask your tachycardia, which is the first warning signal for hypoglycemia. So hypoglycemia la tachycardia வரும். But what happens is your beta blockers insulin நீங்க சேர்த்து கொடுத்தீங்கன்னா beta blockersனால உங்களுக்கு வந்து பாத்தீங்கன்னா உங்களுக்கு வந்து it will be masking so that you cannot check for the tachycardia. Similarly, your beta blocker will be delaying the recovery from hypoglycemia by preventing glycogenolysis. So therefore, you should avoid using a beta 1 selective blocker along with insulin. Similarly, propranolol and verapamil. Verapamil என்னது? Calcium channel blocker. So verapamil ங்கிறது calcium channel blocker. இது ரெண்டுமே propranolol, verapamil இவங்க ரெண்டு பேருமே they are going to cause myocardial depression and profound hypertension, depression. Therefore, you should never use these two together. Similarly, beta blockers and catecholamine. In patients on non-selective beta blockers, use your blockade of your vascular beta receptors can predispose to the peripheral vessel vasoconstriction. Therefore, even using a small dose of adrenaline, okay, local anesthetics la use பண்ணுவோம். அதனால தான் it is safer to use plain local anesthetic instead of using a local anesthetic with beta blockers. Then coming to the beta blocker digitalis verapamil. இவங்க மூணு பேரையும் சேர்த்து யூஸ் பண்ணா மூணு பேருமே AV conduction கம்மி பண்ணுவாங்க. Therefore, the patient can go into cardiac arrest. Therefore, you should not give together the beta blockers with verapamil or digitalis. Okay, now coming towards the first generation beta blocker, propranolol. First generation propranolol வந்து பாத்தீங்கன்னா you have this nodelol, you have this timolol, pindolol. இது மூணு தான் நான் உங்களை நான் வச்சுக்க சொன்னேன். nodelol வந்து பாத்தீங்கன்னா லாங் ஆக்டிங் பீட்டா பிளாக்கர், அதனால தான் அதை நம்ம யூஸ் பண்ண ஆரம்பிச்சோம். timolol ஷார்ட் ஆக்டிங் பீட்டா பிளாக்கர். ஸோ எங்க ஷார்ட் ஆக்டிங் தேவைப்படும்? ஸோ இங்க வந்து பாத்தீங்கன்னா ஹைப்பர் டென்ஷன், ஆன்ஜைனா, எம்ஐ அங்கெல்லாம் வந்து பாத்தீங்கன்னா டக்குன்னு உங்களுக்கு இம்ப்ரூவ்மெண்ட் இருக்கிறதுக்காக we will be giving timolol. அதே nodelol எங்க தேவைப்படும்? in your esophageal varices, in your migraine prophylaxis, you will be using a nodelol. Coming to that's the partial agonist. That is going to be a second generation or your cardio selective beta 1 blocker. So remember, you're going to talk about the metoprolol. Metoprolol is a beta 1 selective. They are going to lack ISMA. What is this ISMA? Someone, if possible, you can just put in the chat box. I'll go to the next one. So this is preferred in asthma and diabetics. Okay, so then okay, patient who complained of cold and who is going to feel like while on propranolol goes better with the metoprolol, and side effects are also very less. Therefore, you go for the metoprolol. Next one is atenolol. Atenolol is again a beta 1 selective. They are again going to lack this ISMA. So if I rendu vaati na ISMA solta. What is this ISMA? Someone, what is this ISMA? I'm giving you time for next one. You just think and let me know. Before I move, I want you to just give your answer. Okay, so this is going to be hydrophilic, poor penetration in the CNS. So it is going to be a poor penetration in your CNS, and they are long acting. They are used in the hypertension and angina. Again, it is used in the hypertension and angina. 50 mg once daily you're going to give. So you're going to give a 50 mg once daily. Okay, you're going to give 50 mg once daily. Next, I'm going to move towards your esmolol. Esmolol is again a ultra short acting. It is going to be a ultra short acting. Okay, so metabolized by estrase in your so it is going to be estrase in your what? It is going to be estrase in your blood. This is given as IV. Loading dose is 0.5 mg per kg, followed by 0.05 mg to 0.2 mg per kg you can give. So supraventricular tachycardia, episodic atrial fibrillation. It is used for reducing the heart rate and BP during emergency. Arrhythmias during anesthesia and MI also we can give. So third generation beta receptor antagonist with a putative additional mechanism. What are the additional mechanism? So this will be causing a nitric acid production. So, okay, again, calcium entry blockade, calcium channel blocker, antioxidant property. இதெல்லாம் இருக்கிறதுனால தான் நம்ம என்ன சொல்றோம்னா இத third generation அப்படின்னு நம்ம சொல்றோம். இதையும் நீங்க photo எடுத்துக்கணும்னா can take a screenshot so that you can utilize it. Now coming to the mixed adrenergic receptor, labetalol. So why you use a labetalol? So labetalol they are non-selective beta receptor antagonist. So labetalol is a non-selective beta receptor antagonist. So where you will be using it? So you have this usage of labetalol. Okay, ரொம்ப important. Labetalol will be asked in the exam also separately as a question. So labetalol you're going to use. So you're going to use beta blocking activity will be preventing the reflex tachycardia normally associated with the alpha receptor antagonist. So dosage will be 50 mg PD. It is used in hypertension and hypertensive crisis. You will be using labetalol. What is the adverse drug effect? Postural hypertension, failure of ejaculation, rashes, hepatic damage. Now coming to carvedilol. Carvedilol is a non-selective beta receptor antagonist. Okay, so they are going to be administered orally. Again, it is used in hypertension and congestive cardiac failure. 6.25 mg you will be using in hypertension. Congestive cardiac failure, you will be using half the dose, that is 3.125 mg twice. Okay, so now coming to the partial agonistic action. So bradycardia and depression of contraction at rest are not prominent. Exercise-induced tachycardia block ஆகுது. Preferred in elderly patient. So அங்கெல்லாம் கொஞ்சம் alpha ஓட action நீங்க கொடுக்கிறப்ப it will be helping you. So why you want to give a alpha action also? நான் alpha and receptor antagonist act பண்ணணும். Why I want a dual action அப்படின்னு பாத்தீங்கன்னா it will be preventing bradycardia. It will be exercise-induced tachycardia is prevented. No receptor supersensitivity. Plasma lipid profile is not going to be affected, and it is not suitable for secondary prophylaxis of MI. And lipid insoluble drug like your atenolol, celiprolol, bisoprolol, sotalol, இவங்க எல்லாருமே பாத்தீங்கன்னா they won't produce a sleep disturbance. அது ஒன்னும் problem, and incompletely absorbed orally, no first pass metabolism. Now coming to what will be the uses. Uses பாத்தீங்கன்னா hypertension, angina, cardiac arrhythmia, MI secondary prophylaxis we will be using CCF, bisoprolol carvedilol, pheochromocytoma, thyrotoxicosis, anxiety, migraine, glaucoma, tremors, இது எல்லா இடத்துலயுமே we will be using. So what are the individual effects? So can we see individual effect in next 10 minutes? I can just tell you. Okay, so first one பாத்தீங்கன்னா glaucoma. ஏன் glaucomaல நம்ம யூஸ் பண்றோம்? Okay, glaucoma acute congestive glaucoma இருக்கு, secondary glaucoma இருக்கு, that is open angle glaucoma, then you are having a secondary glaucoma. So in the glaucomasல ஏன் beta blockers யூஸ் பண்றோம்னா they reduce your aqueous humor formation by blocking the beta 2 receptors in your ciliary body. So since they do not cause meiosis, alpha idillanala meiosis cause panadanaala, there is no associated headache or bro ache. So adu illadana da nama beta 2 receptors nama use pannom. So this is why we use beta 2 receptors in your glaucoma. Okay, similarly we can go for tremors la kudukalam, dissecting aortic aneurysm, alcohol withdrawal, inge ella edathilum we will be giving. What is the adverse drug effect? So CVS can exacerbate your CCF in acute MI, and bradycardia cause pannalam, conduction defect, abrupt stopping precipitates angina and sudden death of patient on long term treatment. Respiratory system you already know increased airway resistance, so it is contraindicated in asthma. CNS, it can cause fatigue, lethargy, depression, insomnia, insomnia, nightmare. So carbohydrate intolerance is or tolerance is also impaired in pre-diabetics and cold feet and hand. ஏன்னா இங்க peripheral vascular disease வரதுக்கான சான்ஸ் நிறைய இருக்கு பிக் ஓகேவா. ஸோ அங்க it can get worsen. ஸோ contraindication எங்கெங்கெல்லாம் bronchial asthma, diabetic mellitus, heart block, Prince metal angina, hypotension, and your pregnancy. Timolol is a non-specific beta blocker or used as an ocular drop in glaucoma. Sotalol, again non-selective beta blocker, as an antiarrhythmic action. Pindalol, intrinsic sympathomimetic activity. இப்ப தெரியுதா what is ISA? I always asked you what is ISA? What is ISA? It is an intrinsic sympathomimetic action. ISMA னு சொல்லலாம். Intrinsic sympathomimetic action. That is what ISMA stands for. That is what I was asking you previously. Intrinsic sympathomimetic action. Partial agonist. It is administered orally. Hypertension, angina, migraine. Angala you can use it. Okay, now coming to the this one also, if you want, you can take a screenshot so that receptor blocking agents la எங்கெங்க என்னென்ன activities நடக்கும் அப்படிங்கிறது எல்லா ட்ரக்ஸுமே இதுல ஒரு சார்ட் பாக்ஸா இருக்கு. You can just take a screenshot if you want. Okay, now how it causes inhibition of your norepinephrine synthesis. So சில டைம் என்ன ஆகும்னா your metyrosine அப்படிங்கிற ட்ரக் I told you. So direct actioning வந்து alpha blocker beta blockers லாக் பண்றதெல்லாம் நம்ம பார்த்துட்டோம். இப்பனா adrenergic blocking not just alpha and beta, even it can affect the production of your epinephrine, norepinephrine. Through that they can cause blockage in the adrenergic system. So that is how your metyrosine act. Metyrosine is going to inhibit your tyrosine hydroxylase. It can inhibit your tyrosine hydroxylase. By that mechanism, what happens? It is going to inhibit the synthesis of norepinephrine. So that's how it is going to cause. And second thing is the drug that is going to reduce the storage and release of norepinephrine. So you have this catecholamine depressant. So what are the catecholamine depleters? That is reserpine. So reserpine, it's an indole alkaloid derivative obtained from the root of serpentina. They are going to block the vesicular monoamine transporter. They are going to deplete your vesicular pool of norepinephrine. So it's a slow onset. So sustained effect it can cause. It is used in the treatment of hypertension. It may precipitate depression. So another one I told you at the beginning is guanethidine. So guanethidine almost completely pronated as a physiological pH. So that is why you call it as pharmacological sympathectomy. So the effect is going to be blocking by the transporter blockage. It is also used in the hypertension. So now we know what is a beta blockers, what are the classification of beta blockers. We also know the actions of beta blockers. Okay, I'll give you 5 questions as your homework. Those who are present here, Arshita, Madhavi, Monica, whoever present here, just find this and put in the box in the group. Who classified adrenergic receptor? How propranolol increases its bioavailability? Which beta blocker is used in asthma and what is the reason? What are the effects produced by propranolol in diabetes? And explain the drug interaction in the cold remedies and your propranolol. I want these 5 questions to be answered in the group. Once you are from tomorrow, we will see the next chapter. I think now we have completed entire adrenergic, your cholinergic and adrenergic system, that is ANS. Why I always give importance to ANS first is to understand any topic per se. You go for the respiratory system, you go for the cardiovascular system. In the systemic pharmacology, we will actually discuss about the autonomic nervous system function. That is the reason why I completed autonomic nervous system totally first. So now what you are going to do is you are going to go and revise entire autonomic nervous system. Once you revise entire autonomic system, it will be easy to go for the systemic pharmacology. Is it clear? So and I want all these 5 questions to be answered, or when I upload in the YouTube, you can also answer in the chat box. So in the comments, you just complete this 5 question. I want the answers for this 5 questions either in the group or as a YouTube comment. Okay, so thank you so much. I will upload this entire session in YouTube also. So thank you so much. We will meet you soon with the next topic in pharmacology.